So as part of this session, we are going to talk about office and the patient management. So this is more kind of giving you the insight about what happens outside of the payer, where what is the pre-process before the insurance companies, insurance which is your payer, comes into the picture. So let's start understanding that. As part of this session, these are some of the topics what we are going to cover. And as we see here, we have information exchange, medical records, managing new patients. Outside of that, we will also be talking about managing established patient and what is clean claim. Now, these are some of the terms, these are some of the terminologies what we have in place, and this is what this overall session is going to talk about. This is what this overall chapter is about. Let's start with information exchange. So when we talk about information exchange, what exactly we are talking here? That's what we need to understand. So think, as an analyst, as a quality assurance analyst, or whether you're talking about as a business analyst, these are the three sides you have where you have to do the information exchange. So as we see, we have clinical side of it, then we have the billing side of it, and then we have the office reception. So the entire process staff is sitting here, where moreover this is the front face to the customer. And who is the customer in this case? The patient is considered a customer, because patient is the one who is going to trigger the entire process. So in this case, as we see here, we have the office reception, which is going to take calls and handle the reception. That's what it comes down to. So when we talk about handle the reception, you have a receptionist who is picking up the call and asking about that, okay, whether you are a new patient, whether you are a returning patient, how that works, we'll talk about in the later session. Then we have the patient registration. So if someone comes into the office, again the office reception is going to take care of that and make sure that the registration form is filled out. If someone is a new patient, the registration form will be the first step. But if someone is just kind of a follow-up or something, then they already have the details in place, but you will be moreover asked the generic question, is there any change in the address, phone number, anything like that. Encounter form, okay, encounter form is like, okay, what exactly the services the patient has. So see, the office reception is listed over there, but is it everything before the patient is seen by the by the physician? No, there are a few things which could be just immediately after the patient was seen by the physician. For example, I'll explain that. So what happens when the patient walks into the service, walks into the premises, given a copay, the insurance verification is done, and then you have the encounter form which gets filled out. So when you walk into the physician office, then they are doing the verification? No. They would have taken your insurance detail and they would have contacted the insurance prior to that. Now, then you have the encounter form. Encounter form is something which translates what service was provided to the patient by the physician. That gets filled out into the form. That's what encounter form is, which is done after you are done with the services. So that is more of a kind of an administrative part of it on the receptionist side. Then you have the billing side of it. Now the common functionality between the billing and the clinical is, the clinical is more where you have a lab, x-ray, any kind of a physician treatment, blood work, any kind of a document. Let's say the document, maybe the physician and the specialist is doing the exchange of the data. So all the clinical records related to the patient. And then other side you have the billing, which is your medical coding and the charge entry. Then auditing, how that audit happens, that okay, they make sure that audit department just make sure that you are in line with all the rules and the parameters to make sure that you are doing the good way of business, good way of practice, good practice. Then you have the encounter submission, which is that encounter form, what we see over here, gets submitted to the insurance. Payment reimbursement. Payment reimbursement is like, okay, which claim needs to be priced how. That billing department needs to make sure as well. Then you have an insurance follow-up, collection, checkout. So these are some of the things which you need to understand, which is there, and that company, that premises are looking after. So again, there are many things. It's not only just this. The overall intent over here is to showcase the information exchange. So these are some of the examples which are given over here to showcase how the information exchange is happening. So these are some of the areas that clinical will deal with the billing, billing will deal with the office reception may deal with the clinical. So it's a triangular process, it's a circular process. Office reception may call out the lab and asking for the result. Clinical may call out the billing department for submitting the bill. So it's a circular process. It goes on and on and on till the case is completely closed. So this is all about information exchange, which happens in the industry, within the industry. How that happens, what format it happens, we'll talk about when we talk about the electronic exchange. Then we'll talk about how the information exchange happens. So this is just to give you the overview that these are the different bodies which interact, but there are many more. Now we are talking about clinical staff can also send information to these sources regarding their patients. The billing office can resend or receive referral to specialists. These are some of the data exchange examples what we see over here. Now then you have, they can also acquire pre-authorization, which are promises of reimbursement from the payer. So what is pre-authorization? Pre-authorization is just an approval which says that, okay, this service is confirmed service and your payment is confirmed, so we approve it. Now the question is, how is the information exchanged so quickly? And the answer is, a reimbursement staff may utilize any of the communication system or mode of the effective billing process. The clearinghouse, see, there is something called reimbursement specialist. These are the positions which are out there. Now the reimbursement specialist is very aggressively working on more on the billing side of it, because they are the ones who knows how to submit a bill, how to create a bill, how to put the correct code, what code will have what price associated with it. So these are the reimbursement specialists. Now the clearinghouse is the entity or business which connects all the dots. Clearinghouse acts as a middle layer between physician office and the payer and makes sure all the information exchange is in compliant with the regulation. So again, why we are talking about information exchange, why we are talking about audit agencies, why we are talking about the clearinghouses. The audit agency is the one who is just making sure that all the exchange, all the data is in compliance with the regulation. On the other hand, the clearinghouse is kind of a private organization, the third party, who deals with the insurance and the physician office, because the clearinghouse is working as a middle layer who have expertise in making sure the data exchange which is happening is in compliance with the industry standards, so that there are no penalties and nothing is applied on that. Now, talking more than that, also remember that they are the ones, when I say they are the ones supporting all the formatting issues. So when I use the word they are, means I'm talking about the clearinghouse. So how they can make sure that the data is in compliance with the regulation? What they do is, see, if you have a physician 1, physician 2, physician 3, physician 4, physician 5, if you have so many physicians, what happens? You are going to have all these physicians using their own application. And when I say their own means they not necessarily build up their application. They are on a different application what they are using for their day-to-day work. That means their input and the output data format could be different. So what they are sending it to the insurance company, someone may be sending it in a flat file, someone may be sending it in the text file, someone is sending it in a different format. How the insurance company is going to receive that? Some insurance companies have these middle layer in between, making sure all the data gets converted into one appropriate format. And then it gets translated over to the insurance company so that you have the consistency in the data. What you are doing is you are trying to avoid maximum formatting issues by doing that. But the question is, Amdion is a very big company. Just remember that Amdion is a very big company. Now, outside of that, also remember that when we are talking that, it is very much essential that do not assume that all the organization is working in this mode. Many of the organizations have no middleman, no middle agency who is acting as the clearinghouse. So that means they are directly dealing with their trading partners. And who is the trading partner? Trading partner is the physician world, provider world, who is dealing with the data, who is sending the data and receiving the data. Now moving on. Medical records. Let's talk about medical records. What is medical record? In a nutshell, if we need to understand, in a layman language, medical record is nothing but all the data related to the patient which is being captured. So if you need to understand in detail, understand this. As a thumb rule of this industry, which is the healthcare business, all the treatment and the administrative processes needs to be recorded. There is no workaround outside of that. That is a thumb rule of this industry. Not only just recorded. Recorded means you do not record it on an audio file. Record means you are maintaining a log of it. You are maintaining a history of that. And has to be saved for the patient medical record. That's what the medical record is all about. So it is considered a legal document. There are many HIPAA rules around that. Medical record should have the details like you can consider date of service, what diagnosis was performed, what was the outcome of that lab result or the X-ray, is there any medical history the patient have, what kind of a medication patient have taken in the past or taking it right now. So if you recall, your physician does ask that question, are you taking any medication? And that gets noted in your record, in your medical details. So as it says, the medical record should have the details like date of service, illness, diagnostic performed, and associated results. Any allergies, patient medical history, medication details, etc. So these are a very crucial information. It is crucial that the documents are maintained in its original form, means the information is an unaltered information. What does it mean? It means, let's say we are talking about that you provided some information, some lab work or something, and physician have it. Now the physician data should be secured enough to make sure no one can get hands into the core data, which is your base data, which is the true valid data, and make some modifications. It shouldn't be happening. That's what it means, unaltered information. That means that is the single source of truth you have in place, which cannot be manipulated. Because again, we are talking about the medical records, and that is very important. Now we are talking about managing new patients. So now we are getting into the mode of understanding what exactly the type of patients we have. Who are those patients? Now the biggest question over here is, why do you have to understand that? You have to understand that because these are the things which is going to drive how the claim is being submitted. What kind of a procedure is being submitted on the claim? So when, let's say, you are working as a business analyst and you need to analyze a claim, how you are going to do that if you do not understand what exactly is new patient and what is established patient? You will have really hard time doing that. So being said that, patient who has not received any professional services from the physician or another physician and or healthcare professional of the same group, same specialty within the past 3 years, that is considered a new patient. See, if you have a patient who is walking to the premises, walking to the physician office, who is been never with that physician, that is absolutely, it's a new patient. But you have a patient who is kind of a, maybe the patient was seen by the physician, but it was more than 3 years back. That patient is going to be considered a new patient. Also, if the, let's say it's a Garden State physician we are talking about. If we are talking about Garden State physician, that means it's a group what they represent. Now they represent a group of physicians under same umbrella. Now you may be seeing one physician under that group, and after 1 year you are being seen by the another physician. So the question over here is, are you a new patient or an established patient? In this case, you will not be considered a new patient. And why is that? Because you are patient of the another physician in the same premises. And when I say the same premises, means I am referring to the Garden State physician, double quote. I am not referring to the different office location of Garden State physician. I am talking about the same physician office, same business, same group, just the different physician. So you will not be considered a new patient. You will be considered an existing patient. Now, billing and coding information. So the following code may be used to describe new patient encounters. Encounters is the service given to the member by the physician. Always remember this term, encounter. You will hear that a lot. 92002 is the procedure code, and 92004 is also the procedure code. That is their long description. Now what exactly this is for? This procedure code can be used for new patient, but cannot be used for the existing patient. So that's how you know. That is the reason why it is essential for you to understand, to use this. How to understand what exactly the new patient is and what is the existing patient. Or you can say it as a more appropriate way is established patient. So these are the codes which tells whether the patient is a new patient or the patient is the existing patient or the returning patient. Now let's move on. Now we are talking about some additional codes. As you see here, we have 99201, 99202, 99203. Just look at the very beginning. Office or other outpatient visit. Office or other outpatient visit. Office or other outpatient visit for the evaluation and management of a new patient. Now, see, when they are saying office or other outpatient visit, first of all, you need to catch here is what is outpatient and inpatient. These are the two different keywords. Very popular in the healthcare industry, very commonly used in the healthcare industry. Then the question is what exactly it is. When we say outpatient or inpatient, always remember, as it says, don't try to memorize it, just try to understand that. Inpatient means where the patient is going to stay in the hospital over 24 hours, overnight. Whereas inpatient, that is your inpatient. Outpatient is like same day surgery, like the patient was hospitalized in the morning, maybe around 8 o'clock or 9 o'clock, and then in the evening the patient is discharged. That is the same day in, same day out. Whereas if the patient gets into the hospital in maybe 8 in the evening, 8 p.m. in the evening, and next day morning, the patient is out maybe at 10 o'clock, 11 o'clock, not considered a same day. That is the difference between the inpatient and the outpatient. And you really have to, you may not necessarily have to remember these numbers, because these are the procedure codes which are billed when the physician is billing for the new patient. That's how they know, that's how the insurance know that, okay, this is a new patient. But as an analyst, do you have to remember that? And the answer is no. Now let's talk about managing existing patient, which is called as established patient. That's the industry term. So if you think, one must be wondering, why do I need to know how the patients are managed by the physician office? If I am at your place, definitely I will think in that way. I am here to learn healthcare IT, but am I going to learn that? See, I am asked this question way often during my class that, okay, why do we have to learn this? And the answer would be, before you learn how to use the data or the patient information, it is crucial to know how and from where that information is coming. So it's a self-explanatory answer. What do you see here? What are the different conditions which needs to be satisfied to make sure the information is captured accurately? Not only that, to understand claim processing, it is important to understand how the physician works, physician office operates, and how do they submit the encounters, which is your member providing services to the physician providing services to the member. That is what encounter is all about. So that is the reason we are saying that we need to understand that. Now let's talk about what are managing patient. Now see here, these codes are used to bill for established patient being seen in the office. An established patient is defined as somebody who has been seen by you or a physician in the same specialty in your group within the previous 3 years. So the time limit is 3 years. There are 5 levels of care for this type of encounter, which all require documentation of 2 out of 3. See here, we have here evaluation and management codes, history, physical exam, and the MDM. Now what exactly all of these things are, that's what we need to understand. So this is exactly you are looking at from the physician side or for the insurance company side. This is exactly how you are looking for. So what we are trying to understand over here is, let's look at this, okay? You have a level 1, 2, 3, 4, 5. There are 5 levels how any insurance can bill. 99211, 99212, 13, 14, 15. These are the evaluation and management codes for established patient, for existing patients who is returning within the 3 years of timeline. What the provider is looking for, providers are responsible moreover to make sure the appropriate level of service is given. So therefore they are expected to understand the evaluation and management, which is this number 1 column. This evaluation and management. Pay closer attention to these stars. So as you see, this is the legend of this. Evaluation and management quarter, expanded problem focus, medical decision making. 3 is here, 2 is here. Now, let's talk it through. Now, when we are talking about evaluation and management, you need to understand that any kind of a misunderstanding, the guidelines leads to non-compliant habit. And that we are talking about undercoding, overcoding, these type of problems. And what exactly those problems are? Those problems means either the medical coder have underbilled or the medical coder has overbilled. And how that is going to happen? So when they are the reimbursement specialists are reporting all these things, if they don't have a clear level of understanding, they may underbill or they may overbill. Now, the medical necessity or the consistently billing the same level of service. These are two different things. Think about the someone doing it intentionally or unintentionally. The overall thing is they are incompliant. They are not in compliance with the data. They are non-compliant with the practices, which is a serious offense considered in the healthcare industry under the fraud investigation. So if something is identified, it will be treated as fraud, no matter whether you did it intentionally or whether you did it unwillingly or whatever it is. So the first step is to understand the evaluation and management, which is your number one E&M guideline, how to bill, whether it is a new patient, whether it is an established patient. In most cases, there are three components: history, examination, and your medical decision making. So these are the three areas, key areas. Out of these three areas, you must have 2 minimum submitted to be eligible for the payment processing. Now, the primary component in selecting the level, each of 3 key components must be thoroughly understood, and let's talk about what these levels are. So you have a history. The problem for which you are seeing the physician, are you seeing the physician because you have a history of that problem? See, many people have sinus, many people have migraine, many people have diabetes. Is it a historical problem? Maybe someone in their family already have it. So it's a historical hereditary coming. Or maybe it was in the history. And that history could be family history and individual history. You have a physical exam, whether this is a follow-up or this is just you are identifying as part of the physical exam. Then you have the medical decision making. Medical decision making, as you see here, you have a straightforward, low, moderate, and high. That means what level of decision is required by looking at the history and the physical exam. That is on the physician. So depending upon that, physician is going to utilize the time, whether he has to spend 5 minutes, 10 minutes, 15 minutes, 25 or 40 minutes. Depending upon this, they are going to get paid. Let's talk very detailed evaluation and management. What do we see here? EM services are appropriate. The medical record should be complete and legible. The documentation of each patient encounter should include the reason for encounter, why you are providing that service, history, any relative history you have, family or whether individuals, physical examination findings, whether this was identified as part of the preventive care, which is your physical, or prior diagnosis test result. What is that? You need to document, the physician has to document that. Assessment, clinical impression or diagnosis. You need to do the assessment and how you have to evaluate that particular problem. Medical plan of care, is there, it's kind of a one-time treatment or you need to, how do you plan to do that? Date and legible identity of the observer. So you are saying that, okay, whatever date it is, how did you observe? Doctor usually ask all this question, okay, when did you first time noted that? Did you took any medication back then? How did it go away? Okay, when did you start? When you have started again seeing this problem? These type of questionnaires they ask, and reason being is because they need to put all this information before it goes to the insurance. If not documented, the rationale for ordering diagnostic and all other ancillary services should be easily inferred. Past and present diagnosis should be accessible to the treating or consulting physician. Appropriate health risk factors should be identified. The patient's progress, response to and changes in treatment, and revision of diagnosis should be documented. These are self-explanatory, very simple English. The diagnosis and treatment code reported on the health insurance claim form or billing statement should be supported by the documentation in the medical record. So again, as I said, that when the physician is submitting the bill, that needs to be supported by the facts, and the facts are the actual medical records of the patient, which supports that, okay, this patient was visited maybe 3 months back for this problem and this was the treatment provided. So now he is a returning patient. After 3 months he is returning, or she is returning again for the similar kind of a symptom. In order to maintain an accurate medical record, services should be documented during the encounter or as soon as predictable after the encounter. What it means, what value are you going to gain out of that? The value is the physicians are spending every day so much time with the patient, not individual patients, with all the patients, and they see the patients one after another. Think about it. What time when their memory will be fresh to just give the details, provide the detail what services they provided to the patient to the medical billing and the coding department. Exactly after when they give the services, or towards the end of the day where they sit down after seeing all the patients and then now creating a medical notes to hand it over to the medical coding and the billing department. They will have a better memory and they will do the better record management when they see the patient. So either they update it then and there in the system, because now everything is moving to electronic, so they update it then and there, or they do it exactly after finishing up with the patient, so that their memory is fresh, they know what exactly they discussed with the patient, what kind of a history the patient has, and they do not wait till the end of the day. That is the common practice. They try to do it exactly after that. Now, we are talking about a clean claim. Clean claim, you may not necessarily hear the terms very often outside of the physician world. But on the insurance side, they may say that, okay, have you looked at the image of a clean claim? Means they are talking about that the claim was scanned from paper, and they are talking about that is the actual notes which was provided by the physician to the billing office. That is your clean claim. But very less likely you are going to get exposure to have a look into that. Now, you have a health insurance written contract or policy between the policy holder, whether the policy holder is your group or an individual, and the payer, which is the insurance and the company. In that overall process, a claim is the most important phase in the overall reimbursement process. Reimbursement process is nothing but how the claim is being paid to the provider. It starts from the time patient being treated by the physician, and where it ends when the money is collected by the member and the provider is paid completely. It is up to the reimbursement staff to send the encounter or bill or claim to insurance company for the rendered services. So what services were provided to the patient. A claim is considered a clean claim when have all the accurate and necessary information to support the correct reimbursement by the insurance company. That means all the necessary information to process the claim is being captured as part of the clean claim. Then only it is considered a clean claim. If there are any issues, then what will happen? The claim will go to the insurance company. Insurance company will reject the claim, specifying the reason why they rejected the claim. For example, the reasons like the procedure code is incorrect. Now the procedure code is incorrect, that could be also many different reasons. The reason why I'm sharing that, so that you talk like a real-time professional and you really understand that. So what kind of problems they see if the claim is not a clean claim? The problems are something like this. The medical coding and the billing department have used the code, the procedure code, which is expired. See, they also have, each procedure code have a start and a term date. So unless the termination is done, that is considered as a effective one. But the moment the term date is provided for that procedure, it is considered a terminated one. So it has to be inconsistent. The procedure code which is being submitted, it has to be active for that particular date of service, not necessarily for the day it is being submitted. I'll give you the detailed example. Think about it. The claim is for 1/1/2014. That is your date of service. Claim being submitted after 30 days. So the claim is being submitted on January 31st, 2014. Now there is a 30-day lag. But what happened in between? Your claim coming into the healthcare system on 31st of Jan, whereas your date of service was 1st. The procedure code which is being submitted, the procedure code is getting expired on 15th of Jan. In this case, what will happen is, by the time the claim is being received, it's already 15 days of expiring that particular procedure code. So the question is the claim is going to be rejected because of the incorrect expired procedure code? And the answer is no, because when the service was performed, which is on January 1st, in that day, that particular procedure was active. That procedure was effective. That was not expired. Whereas the another situation that, okay, your claim was submitted on 31st, but the code is expiring on, or sorry, your date of service is after 31st, that would be considered the claim will be rejected because it is the incorrect, inconsistent procedure code for that particular date of service. So now, before we started talking about the clean claim and all those things, we have understood what is patient registration and the reimbursement, how that works. But we have also talked about the policy and the policy holder, where policy holder could be your individual or a group, and the payer is your insurance company. These are the three parties, what we see over here, these are the three parties who are part of this contract, where your policy holder is working in conjunction of this contract with the insurance company, and the physician also have the, let's say this is the HMO contract, member also have a HMO plan, and the physician is in the HMO network, and both are tied with the insurance company. Now, claim is the most important thing. It is a core of the payer, because everything is about claim. You need to make sure you are paying the claim correctly. Now let's move on. This is your sample patient registration form, where you have, I'm just going to give you the high level information about this to understand, because every physician office have a different type of patient registration form, but again it comes down to, moreover, everyone captures the same piece of information. Patient last name, this is all the patient demographics. Then you have the patient social security, and this is all comes under the personal info, which is a demographic. Choose clinic before referral to clinic by, okay, you have a doctor name, and choose an item. So these are the kind of a form, you can Google it and you'll find plenty of patient registration form. If needed, you may be able to see the sample of this patient registration form as part of the data also. Then you have insurance information. Insurance information is moreover to capture whether this you are yourself is the subscriber. We have talked about the subscriber before, or somebody else is the subscriber and you are a dependent on that subscriber. So always you need to provide the social security and all those numbers like group number, policy number. From where you get that all these piece of information? From your insurance card. Then you have, in case of emergency, who should be the go-to person. You provide, that means that person you are authorizing to say if there is an emergency, this person can be contacted. Many people put their spouse name, many people put their friend's name, many people put their parent name. As long as that authorization is there in case of emergency, that's the person who will be contacted, because that is the registration form which you have submitted. We don't see it in the bottom, but there is the other part of this. See, this is your patient signature and the date and everything, but there is another part of it. Usually you see, it says something like that, I authorize my insurance benefit be paid directly to the physician, something like that. Or it may say that I understand that I am financially responsible for any balance due. I also authorize ABC Pediatric LLC or insurance company to release any information required to process my claim. So moreover, you are authorizing by signing all these things, they are forcing you to give that authority to the physician to work with your insurance company. So by signing all these different type of documents, the patient is authorizing the release of information, how the information will be released. So in case of emergency, for example, you have given the data that, okay, the information will be released to this person, to this contact, what is listed over there, only in case of the emergency. Then it also demonstrates the general release used for this rationale. And the releases can be included on the encounter form and set aside on the file for billing area, because that's something which they may use on given point of time to say that, okay, you did approve this person to say that, okay, any piece of information can be released. So this is the patient registration form, just the sample. What do we see here? So this is a gradual step, that's what we see here. So you have a patient appointment, then patient checks into the office, then the patient registration. If the patient is new, registration. If not new, then you skip the patient registration part. Then you have the collect co-payment. Patient is seen by the physician. See, all these things we have talked about, but what we see over here is the sequence of it. So all the treatment information needs to be documented properly, and using this document, the necessary medical codes are assigned for the patient encounter. Also, the demographic gets updated in the billing system. Then you have a claim is entered. So as we see here, the claim is entered into the billing software. Depending upon the type of claim, corresponding form will be filled out. When I say corresponding form will be filled out, means if it is a professional claim, if the claim is being submitted by the physician, it will be CMS 1500 claim, which we will study in the chapter CMS 1500. If it is the hospital claim, institutional claim, it will be submitted on the institutional claim form, which is UB04, which is uniform billing form, which again is another chapter we are going to study. Now, there is a different way how both the claims get submitted. There is a difference, which we will understand in detail when we get to those two different chapters, which is your CMS 1500 and your uniform billing, how the hospital submits the claim. So now finally your claim is ready to be submitted electronically. And what do we see here? So all this information is there. So here now your encounter is ready to be submitted to the insurance company. So what happens next? The claim is received by the insurance company, and how the insurance works, which is being broken. So in between these two, there are many steps. which you will learn using different chapters, like we have EDI, claim processing, then CMS 1500, uniform billing. All these are different chapters which comes in between over here. Once the insurance completes the cycle of payment and cutting out the check and everything, then again it comes back to the physician side of the world, where if there is any balance due for the member after the claim is paid by the insurance company, they will send out the follow-up or the collection letter, depending upon how that works. So that is your completion of your healthcare office and the patient management, how the thing is done. And that completes your session for this particular